Good evening, good evening. Over the crunch of the tacos, we're going to try and get ourselves started for our discussion at our symposia this afternoon. Thank you all for attending. I'm very pleased to introduce to you our speaker for this evening, Dr. Randy Loftus. Dr. Loftus is currently Associate Professor of Anesthesia Critical Care at the University of Iowa Healthcare. At the beginning of Randy's career, he had a very early interest and continues work diligently over many years here, establishing a foundation of evidence linking bacterial transmission in the operating room to post-operative infections and increased patient mortality. He has published many articles on this topic in peer-reviewed journals and has been awarded multiple grants. Recently, Dr. Loftus was honored to win the ASA President's Research Award. Congratulations. Dr. Loftus is active in several medical associations and serves as an ad hoc reviewer for a number of peer-reviewed journals. A highly sought-after speaker. He has spoken at APIC a number of years. He's been invited to speak both nationally and internationally. Please give a warm welcome to Dr. Randy Loftus.
Well, thank you very much for that kind introduction, and thank you all for being here tonight. And I was thinking about this a little bit earlier, and to see all of you here is just very flattering to me because I can't imagine, from your perspective, having to listen to an anesthesiologist talk about infection control. But I'm going to do the best that I can to make it worth your while. And we're going to talk about mapping bacterial transmission in the operating room environment. And I have three major goals here. The first thing I'd like to do this evening is to build the base to characterize what is the problem that we've detected in the operating room, what we've made anesthesia providers and surgeons aware of over the last decade. And then after I've constructed that base, I want to talk about what are the solutions that we've looked at in the OR that are specific to the OR that can be used to solve the problem. And my hope is at the end of this talk that you will be empowered to take the information that I provide and the evidence that I provide and go back to your institutions and effect change, because change in the operating room and the perioperative setting is desperately needed. It's something I'm serving as a champion at the University of Iowa, and to date I can tell you that it is desperately needed at our leading institutions. So that is my hope. I do have some disclosures. They're all listed there. I work in bioinformatics. I've received research support, and I want to thank B. Braun for providing the opportunity for me to speak tonight. They have provided an unrestricted educational grant that allows this to occur. So over the last decade, I've been working off of a central hypothesis, and that is if we can achieve a better understanding of how different bacterial pathogens transmit in a given environment, then we can use that information to generate evidence-based ways in order to reduce bacterial transmission events. And as those bacterial transmission events are reduced, healthcare-associated infections will undoubtedly fall. Now, my focus has been on the OR, but I've also done a significant amount of work in the intensive care unit, and currently I'm extending my work into the preoperative setting as well and into all of the postoperative arenas. So, back in 2006, let me see here. So back in 2006, we designed our first study, and the purpose of this study was to characterize the overall magnitude and the significance of bacterial transmission in the operating room, because one of the chief quality safety officer, George Blake at Dartmouth, came back from a National Patient Safety Foundation meeting, and he said to me, I was participating in the clinical research scientist track, and he said, Randy, if you want to change something in medicine, if you want to make a difference, then figure out how to reduce infections in the operating room, because nobody's figured that out with certainty yet. And so he inspired me to take a look at this. So when he said that, my eyes were wide opened up for the first time, because I too, at that time as an anesthesia resident, had no vision that anesthesiologists were at all involved in that issue of postoperative infection development. So we designed a study at Dartmouth to determine whether or not that was true. And it was a randomized prospective observational study that involved 62 operating room environments. And the reason why we used a randomized study design is because our hope was that the results would reflect the overall perioperative setting and not just a specific subset of patients. So what we did is we designed a very simple experimental model to study cross-contamination of bacteria. And the model was, we work in the anesthesia environment, let's look at ourselves first and see if we can detect anything, and then we can spread this to the rest of the operating room. So we focused on mapping out the OR. We did pilot studies to figure out what areas of the OR would best represent the overall magnitude of bacterial contamination over time. And we published our first abstract at the American Society of Anesthesiologists. It was titled, "Are We as Clean as We Think?" And the answer was a clear no, we're not. And I'm going to show you some of the data. But what we did in this model is that we found that there were two sites on the anesthesia machine that best reflected bacterial contamination in the OR during the process of patient care. And that was the adjustable pressure limiting valve of the anesthesia machine and the agent dial. Those two sites were best reflective of that. And then we also looked at internal lumens of stopcock sets. And the reason why we did that is because it's not uncommon to see one of those open lumens laying on the floor and with a footprint on it and open to the air and propofol inside of it. And we thought, now, I wonder how often these devices are contaminated, and does that matter? So this randomized prospective observational study was conducted, and we decontaminated the environmental sites at baseline so that we had a clear slate to work from, so that we could measure contamination at the start of the case and at case end. And bacterial pathogens that were present at case end that were not present at case start, we consider those to be transmission events. And then the stopcock, it was invariably negative on removal from the packaging material, so any organism present in the stopcock at case end was considered a transmission. So those were our primary aims. Not surprisingly, when you look at the contamination of the OR environment, here's where these are colony-forming units per surface area sampled at baseline here. Oh, by the way, these slide sets that you're following don't match these because there were changes at the last minute, so I apologize for that. There's always changes. So, okay, so the content is the same, but the pages don't match. So this is the baseline, and then this is the case end. So there's a significant increase from case start to case end, and that is statistically significant, and the magnitude of that is about 120 colony-forming units per surface area sample. Now, that's going to turn out to be an interesting situation. Now, this contamination occurred very quickly, in as little as 4 minutes, this change in contamination. And what we found is that if you look at stopcock contamination, about a third of the time they are contaminated with bacterial pathogens, Staph aureus, gram-negatives, different types of organisms, coag-negative staph. And as the contamination of the anesthesia environment increased, so did the probability of stopcock set contamination. And it was about 100 colony-forming units per surface area sampled where that threshold was met. So the environmental contamination was directly, or at least in this model, indirectly related to stopcock contamination. So this is a key point that I want you guys to focus on because it's going to come up time and time again as we go through this. When you look at what gets injected into a stopcock, the question is, does it matter? And so what we did is we used the old school technique, which was the gold standard back in 2006 of pulse field gel electrophoresis as a molecular typing mechanism. Here are your ladders on the outside. This is VRE that was found in the environment. This is VRE that was found in the patient's stopcock, and then this is the organism that killed the patient 48 hours later from septic shock. And the patient was not colonized with VRE, so this was a direct link to an infection. So we thought, well, this was a small study. We were able to find one link. Is there an association statistically with increased mortality? And we found that there was. an increase in mortality that was significant. It was a secondary outcome. We cautioned the reviewers of this and the readers. And we concluded from this study that, we're not as clean as we think in the OR. We transmit a lot of bacteria. There's some relationship between the contaminated environment and when we inject bacteria. And when we do inject bacteria, it looks like there may be a significant association with bad outcomes such as infection and mortality. So further work was required to address this. But what was interesting is that when I presented this would characterize most of the anesthesiologists at the time. I don't know if that's the way they are to date, but I think even where I'm at today, many of them are, and I have to wake them up from time to time. So in order to wake them up, this is what I did. I cultured a toilet seat in the hospital in the middle of the day, and then I said, here's your environment. And I said, your environment is very akin to a bathroom, the toilet seat of the bathroom, and I said, we have a lot of work to do to improve this. And when you show them this picture's worth 1,000 words, they get it. The area is dirty. What am I bringing home to my family? Why am I getting exposed to these things? And you start to get a lot of questions about that. So where they want to know, where is it coming from? It was one of the questions. So we figured out if we have a lot of contamination, first of all, are those results reproducible? And can we figure out what is the source? And so we conducted another study at Dartmouth Hitchcock Medical Center. It was, again, a randomized prospective observational study. And we enrolled 82 case pairs, 164 total patients. And we looked at the primary outcomes, again, of transmission events that involve the environment. And we looked at stopcock contamination rates. Now, the Centers for Disease Control says that hand hygiene is the #1 preventive measure, and I think that's still true today. So the logical place to start was with the hands. And we know that we need to wash our hands before we provide patient care, during and after, especially before and after, that's emphasized. So we started with before. So we expanded the model a little bit from baseline environment, case end environment, and the stopcock at the end to include the hands of the provider when they walked in the room. There's a wall-mounted alcohol dispenser on the wall. So they had an opportunity to wash their hands. After they came in, past that opportunity, and we're going to provide patient care, we used a modified glove juice technique where it's been used in the cystic fibrosis literature to take the transient layer of the flora off of the provider's hand, and it gives you a fingerprint of what they're carrying. And then what we did is we tried to detect transmission events to the environment and stopcock sets. And we compared the organisms that we found using a series of phenotypic tests and molecular typing to say, are these organisms on the hands of the provider at baseline epidemiologically related or not to what gets transmitted? And so what we found is that in 89% of cases, we had contamination in the environment, which is not surprising. And then when we looked at whether or not providers were the cause, at least a probable cause of that environmental contamination, they only explained about 12%. But then when you look at contamination of the stopcocks, again, we were able to find it fairly frequently, but I was working with a fellow at the time who was killing all of the organisms, so this rate is much lower than the previous rate of 32%. But 47% of the time, we could show a very strong relationship between what providers had on their hands when they came in and what got transmitted to the stopcock set. So it's not the majority. And so we concluded from this that yes, hand hygiene is important. We need to do a better job, but there's got to be more to that. So what we did is we said, let's expand this beyond Dartmouth. We need a multi-centered study. We need to look at the relative contribution of known reservoirs to these events. So we expanded the model again. Here's the adjustable pressure limiting valve and the agent dial. Here's your stopcock set. So those stayed the same. We measured the hands before patient care, but then we measured them during and after patient care as well. And we expanded it to case pair, where we have case 1 and case 2, so that we could look at transmission events occurring within a case and between cases. So the goal was to mirror vertical and horizontal transmission as thought of on the floor by you guys in infectious disease. So we worked at the University of Iowa, Dartmouth Hitchcock Medical Center, and University of Massachusetts. And we applied this model. We randomized 274 case pairs to observation. And we sought to look at the relative contribution of these reservoirs to stopcock transmission events as the primary outcome. And then as a secondary outcome, we were looking to see if the relationship between stopcock contamination and increased patient mortality was upheld with different people collecting at different institutions. And so what we found is that here we have a contamination rate of 23% of cases overall. And when you look at the source of within and between case modes of transmission, within case, the environment is the primary driver, and that gets back to that relationship between the environment and stopcock contamination that we demonstrated in the early study. So here it is again, providers 30%, patients 23%. When you look at transmission between case, the environment plays an even stronger role. And so clearly there's room for improvement in the environment, but again, providers and patient skin services are playing, and I forgot to mention we sampled patients in that model as well. The nasopharynx and the axilla are playing significant roles. So we concluded from this that if you're going to address this transmission and prevent contamination of intravascular devices in the OR, it has to be multimodal. That asking anesthesia providers to wash their hands is not going to solve the problem. It will help, but it will not solve the problem. So then we said, well, do we need to do this? Can we confirm that there are any significant implications of these events when they do occur? So when you look at, we follow patients for 30 post-operative days to determine if they developed a healthcare-associated infection. And that was defined by the National Healthcare Safety Network. And 8% of patients, 44 patients, were infected with one or more HAIs. 30% of the time, you could find the organism that caused the infection in one of those tested reservoirs during the procedure. So that means that there's the potential to eradicate the presence of that organism. So, and again, we use pulse field gel electrophoresis. So again, there was a link of the anesthesia work area reservoirs to postoperative infection development. And then if you look at the association with stopcock set contamination and mortality, and you do multivariable analysis, despite adjustment for all these potentially confounding variables that may impact this, contaminated stopcock sets had an odds ratio of 58.5, which was statistically significant. And the only other factor that seemed to play a role was the American Society of Anesthesiologists health classification status. So again, now we have this has been repeated, it was upheld in a multi-centered study, that bacterial transmission in the operating room is common, and there are significant implications. So just to summarize this early work, bacterial transmission is of significant magnitude, it occurs frequently. It's directly linked to postoperative infection using molecular typing techniques. It's associated with increased patient mortality repeatedly. And if you're to implement a best practice based on the data to attenuate this, it would include a multimodal program to address this, not a single solution. So that, in my mind, and in my team members' mind, at the end of that would include improved vascular care and design, improved hand hygiene, improved environmental cleaning, addressing patient decolonization, and then surveillance is a key method, which is an evidence-based method to optimize the bundle that you implement. And that's what we're going to talk about in a little bit. But so we went on to construct a bundle, an evidence-based bundle to address this, and my hope is I can provide you with some tools that you can utilize. But while we were doing that, in parallel, we were considering, what is it that we're injecting anyway? Let's learn more about the bacteria. So Staph aureus sequence type 5 is commonly associated with USA 100. And when you look at the OR and you look at the pathogens that you collect, you're typically going to find 22 different multi-locus sequence types. And the question was, among those sequence types, is there any one that stands out in the OR? And the answer is absolutely yes, a resounding yes, that it's sequence type 5. So why is that? Well, we found that there's a significant increase in the risk of transmission despite adjustment. It's a very significant relationship, and this is clonally related transmission here. We expanded the model to go from systematic phenotypic and pulse field gel electrophoresis to using whole cell genome analysis and looking at, and we're going to talk more about this, but looking at single nucleotide variation differences. So this is as strong as it gets. This is proven. Now, we then said, well, why is there an increased risk of transmission? And it turns out that in part, it's due to the ability of ST5 to form biofilm, and that's consistent with prior literature that's written about USA 100. There's a very significant increase there. And when you look at it, there's also a significant, not only is it highly transmissible, partly because of biofilm, but it's also very resistant to antibiotics. And not surprisingly then, if it's transmissible and it's resistant to antibiotics, then it's likely to be associated with increased risk of infection, and it is. So here's what it looks like in the OR for this particular organism. The question is, are we transmitting these escape pathogens, the ones that are more likely to have acquired these resistance traits and virulence characteristics? And what you find for this organism, MLST5, using a new surveillance system that we've developed, is that patients are the primary reservoir of origin. The intensity of red indicates where the primary origin is, and then these, when you see an intensely red line, that indicates the strength of the relationship between one reservoir to another. So patients are the primary reservoir. Occasionally it's the hands, especially of residents, when you look at the overall pattern of transmission in the ORs. And there's within case transmission, there's between case. The certified registered nurse anesthetists are more likely to be involved in second case for whatever reason. There is patient-to-patient transmission that ends up contaminating the environment. And we've mapped, the system maps out the operating rooms are involved so that we can address this. But this is, like I said, this is a typical transmission pattern, so it's common to transmit MLST5, which is USA 100. Now, that being said, is it surprising that in our hospitals, MLST5, USA 100 is the #1 cause of invasive hospital-acquired infections? We're doing more and more surgeries. We're having a very high transmission rate in the OR, and the OR is largely devoid of infection control measures. So to me, it's not a surprise at all that we have this issue, because we have an area that we have not thoroughly addressed. Now, what about USA 300, a common cause of community-associated Staph aureus? It's increasing incidence of this. It's typically, it can be invasive. It's associated with a significant increase in patient morbidity and mortality, and it's associated with sequence type 8. Is that something that we commonly transmit? And if you use the same surveillance system and you look for that, you will find that we do. Now, it has a different pattern of transmission altogether than USA 100. Here you see the intent, as you look at the origin of between case transmission, it's no longer a patient focus. It's diffused across residents, provider hands, and patients. So when you think about something that's community associated, hand involvement is something that you would think would be more involved, hand-to-hand transmission, and that's what you see here. And then ultimately ends up patient-to-patient transmission. In this case, it's left behind in the environment. And remember that association of environmental contamination and stopcock injection. Here you see USA 300 getting injected into a patient's intravenous stopcock set. Now, this is definitive. Whole cell genome analysis. There's no question that this is happening. None. It's not surprising then if you look at patients who get infected and you use genome analysis to determine whether or not the infection was caused by an organism, that in particular when you look at wound infections due to Staph aureus, that you can find MLST5 and MLST8 linked to the infections. Here's one that was linked that the resident brought in on their hands, caused a wound infection. Many of these are patients, some of them are unknown. Unknown is related to some other reservoir that we're not testing. More likely than not, it would be air as the medium. And then there are some times when you don't know where it came from, but here's the bottom line. 50% of the time, if you look, you can find the organism that caused the postoperative infection was already in the operating room when the patient was operated on. So that means it was preventable, more likely than not. So now, I want to talk a little bit about how strong is this association that we're looking at here with genome analysis. This is the same surveillance system presented in a different way. It's looking at the genomic transmission of Staph aureus isolates that are resistant to drying, to desiccation. more likely to survive in arid environments. Here's an organism on the resident hand in case 1. There are only 13 differences so Staph aureus has 2,800,000 base pairs. The error in genomic analysis can be up to 0.1%, so you could have 2,800 differences just by error. If you look at multi-locus sequence typing, which is commonly used, especially for organisms like tuberculosis, and also for organisms like this, you would see variations that would range from anywhere from 1,200 to 1,500 differences, and that would be accepted as clonally related. In this model of surveillance, I'm showing you that there are only 13 differences in these nucleotide mismatches between the organism that this resident had and the one that ended up on the patient. And then in a 30-day postoperative period later, there was a variation of 108 differences, which was upheld by pulse field gel electrophoresis, which is typically where that ends up landing. When you look at links for PFGE, they're typically around 100. With whole cell genome analysis, you can get links as from anywhere from 0 to 15. Now, you can see here that this patient, this is a typical transmission pattern here. Patient 1 transmitted to patient 2. This is the same operating room environment, very strong link. There's no question at all that patient-to-patient transmission is occurring in the OR and that it's leading to infections. These papers are, some of these are in press, but you'll be seeing them in the near future. So what that means is that this patient-to-patient spread of bacteria, I've already said that we need a multimodal program in the OR and it needs to include decolonization. I know you know that some institutions decolonize patients undergoing orthopedic surgery. Some institutions include cardiothoracic patients. I'm not aware of any institutions that decolonize everybody, but from my basic understanding of infection control, these are usually universal when you apply them, and there's a reason for that, because one patient can affect another, and you never know what's going to happen. One provider affects another, so we apply universal precautions. And based on the data that I have shown, and my understanding of how this transmission occurs in the OR, it's my humble opinion that there's absolutely no reason why we would limit decolonization, which we know is effective, to a subset of patients. There's no reason to do that, especially when you can show that one patient undergoing care in the same arena can dramatically affect another. It's a key target of the CDC, patient-to-patient spread. So I'm going to make a strong argument here that we need to extend decolonization from orthopedic patients to other patients in the hospital, and that's something we're doing at Iowa now. So here's the prior summary of where we were at, and I want to add to that then, that in addition to all these bad things, the transmission that is occurring does involve more pathogenic bacteria that are associated with both hospital and community spread. Okay? You can just simply tell the anesthesia providers, you are injecting the deadliest Staph aureus pathogens that we know of. You can feel free to tell them that, and if they have any questions, have them call me. It's definitive, and you can hand them the papers. And take it to your risk management folks and take it to your perioperative directors. Because we can map it. It can be detected. And if I can measure it with these techniques, it's occurring a lot. We're just seeing the tip of the iceberg here. So, indeed, we need to work together to get multimodal solutions implemented across these institutions. And we need to emphasize decolonization more strongly than we currently are. So back to what a multimodal program looks like, the goal is to implement a series of, a number of different evidence-based techniques that the people that take the heads out of the sand. How do you do that? How do you get their heads out of the sand? You have to implement devices that are evidence-based. If you go to them with tools that are applicable to a completely different arena, just to give you an example, the Kuros cap, for example, and I'm not going to endorse any products here, but the Kuros cap is not designed for anesthesiologists. And I'm going to explain why. Okay, so if you go to them with a Kuros cap to solve their intravascular injection problem, you're going to lose them. So you need to get their heads out of the sand, and you do that with evidence. And there are some evidence-based tools that exist. It's in the literature. I'm going to talk about an evidence-based bundle for this component. I'm going to deconstruct how we can address hand hygiene and get back to some of those basic principles, how that relates to environmental cleaning. I'm going to further discuss this just a little bit further, and then we're going to talk about, I'm going to show you an example of how we're using surveillance today to detect what's going on. So here's a good question. Why, and I'll say it again, why are we still using the open lumen? I can't figure it out. We know it's dangerous. We know it. The question is, are there alternatives, and can you convince an institution and other providers to use them? So the anesthesiologist will say to you, I've got to have the open lumen, and I need it because I need low resistance to injection. I've got to control the fluid pathway. I run pressors, and I can't have those infusion rates slowed down. And what about the dead space? I take care of pediatric patients, and by the way, I have nothing to do with this. Okay, this is what you're going to hear from them. So if you know they're thinking this way and you give them a Kuros cap, you're wasting your time. You've got to give them something that's designed for them. So what I did is I said, okay, I know this is an issue. I've got to take this on myself to come up with an effective solution. So I thought, well, what about a closed disinfectable stopcock set? Yebenis published an article on critical care medicine in 2008. He looked at the microclave. He found that the microclave with or without disinfection was better than other the comparative devices, including, I don't think he included an open lumen, but he compared it to other devices, and he was looking specifically at disinfection or not. And so his rationale for that and his group was that there's a valve that serves as an intrinsic barrier to bacterial entry. Trouble was Yebenis was working in a lab, wasn't working in the clinical environment. We're going to talk about how many bacteria we're actually injecting. He didn't contaminate it enough. So I thought, well, let's look at if there are any closed disinfectable stopcocks on the market. So this is one that was on the market. It's called the Ultraport Zero. Here's the open lumen, conventionally closed with a cap, and the CDC recommends the way to maintain sterility of this open lumen is to close it with a cap. Now, anesthesia providers don't do that very often. Some do. Here's the alternative that exists where it's closed. They still have the stopcock, but it's disinfectable. So what are the different attributes here? First of all, it's a stopcock so that you're in a good place there with that group. They can control the direction of the fluid pathway. Big deal to them. This allows high flow rates, just like the open lumen, and it has limited dead space. And most importantly, they can disinfect it before they inject it. Okay, so I thought, well, this is a good tool to test. Can we reduce the injection of bacteria in the OR if we implement this? So what we did is we designed a randomized ex vivo study that included 468 operating room environments. Now, in each of these environments, providers were randomized to one of three schemes. So in my lab, my technician assembled these devices. They were all connected to a culture media bottle. So it was an IV catheter connected to the device, and the needle, an 18-gauge needle, the device injected in the lumen, connected to a needle that went into the media. Okay, those were the units, the study units. They were prepared sterilely in the lab, brought to the provider sterilely. After they induced the patient, put them to sleep, and they were stable, they were asked to do a series of 5 injections. And they'd say, what do you mean? Well, just go ahead and draw up the fluid like you normally would if you were going to inject this patient with a drug, sterile saline. Yeah, what do you mean? Just do it the way that you normally do it. I don't care. Should I wear gloves? I don't care. Just do it. And so here's the device. I want you to do it 5 times. Draw up 1 ml and inject it 5 times. So they either injected a stopcock that included the closed stopcock with proper disinfection beforehand, so scrubbing it with an alcohol pad, waiting 30 seconds, then injecting it. or they injected the disinfectable needleless device, closed stopcock, without disinfecting it, or they injected the conventional open lumen stopcock. And the primary outcome was, what was the overall incidence in those three groups of bacterial injection? And how do we measure that? We took the units, we removed the catheter, we put the culture media bottles into a Bacti-alert machine, and they remained there for 5 days or until they were positive. And then we cultured the organism. And so what did we find? Well, the device reduced bacterial injection. It was statistically significant. There's an absolute risk reduction of 3.2%. But when you disinfected it, there were 0 cases of contamination. So the Ultraport Zero in this study lived up to its name. If you use it properly, you have 0 cases of bacterial injection, which was statistically significant. It was better than the open lumen. So we definitively have a better alternative than the open lumen if you disinfect it. Now, we took the opportunity to figure out how many bacteria are we injecting when we had a case of contamination in the open lumen or a case of not disinfecting it. And it turned out that we were injecting 50,000 colony-forming units in a series of 5 injections. And they think they're doing it. They're using their usual technique. They're drawing it up as they would normally inject a patient. And this is what you get. And we did see that they injected staph. Now, I just want you to think about for a second. Just think about you're in the operating room or your kid's in the operating room and somebody's injecting 50,000 CFU MLST 5 or 8, okay? And you didn't get vancomycin because the orthopedic surgeon said, you're decolonized, we tested you, you're MSSA, you don't have MRSA. But the bacteria that they injected came from the patient before them, in the case before. And so now you have a case where you've been injected with 50,000 units of this organism, and you don't have any defense against it, and your immune system is suppressed by the anesthesia as well as the inflammation from the surgery. And now you've got a hematoma, and the bacteria sits down in there, and it's a great biofilm former. So it's going to form a quorum, it's going to survive it, and it's going to live, and then you're going to get an infection 30 days later. This is what's happening in the OR. So in our bundle that I'm constructing here, the Ultraport Zero, that is the component of vascular catheter design improvement. We're getting rid of the open lumen, we're closing the stopcock. So this is a change that we've made. Now, we need to get to the disinfection component. How do we get an anesthesiologist to disinfect? It's not easy to answer that question, okay? So how do we do it? So should we ask them to disinfect the open lumen? No. Open lumens are not considered disinfectable, right? Show of hands of who thinks you can disinfect an open lumen successfully, or it's a good approach. Okay, so no, that's not an answer. What about giving them whatever the institution uses for a cap? Get back to Kuros. At Iowa, like they'll use Kuros, or what was the other one called, the swab cap. And you put it in their drawer in the cart and ask them to use it. Well, the issue with that is the answer is no, because they work in a unique environment. And now, let me explain that. In 2014, there were 2 papers published in American Journal of Infection Control. One was by our group, one was by another group. Our paper looked at the OR, and it characterized how many opportunities for hand hygiene are there in the operating room in a given hour for an anesthesia provider. And there are about 149 opportunities to wash their hands per hour. And this is, and above that, you can see that. This is a spaghetti diagram of a routine hysterectomy. Here's anesthesia, the red, and every red line represents an interaction between the provider, their environment, and the patient. So you can just see they're just going, I just had somebody sit in a room and map this out. So here they are. You can see that this reflects this. Now, if you look on the ward, they looked at 26 hospital stays. We used video observation. They used video observation. They found that the number of opportunities to wash their hands according to WHO was 3. Now, our paper is backed up by Chuck Biddle. I don't know if you've read his work, but Chuck Biddle found similar observations, and this is consistent within literature as well. So this environment is not the same as this environment. It's about 50 times busier in the OR. So if you ask an anesthesia provider who knows that to use the tools that they're using on the ward, they're not going to do it because it's not designed for them. They know that. That needs to be addressed. So the question was, is there a system that actually works that's designed for a fast-paced environment? So here we have a catheter disinfection system. Now, this is called the catheter care station. It has a lot of interesting components. First of all, it attaches to the IV pole or whatever pole the anesthesiologist wants to construct. It doesn't matter. It just has to attach by a clamp. And it holds the IV tubing off the floor so they don't step on it. And it also has these caps called the hub scrub. Now, what's interesting about these caps is that they have brushes on the inside. When you think about disinfection, you have to have a mechanical disruption if you're going to do it well, and you have to have a disinfecting agent. So they include isopropyl alcohol. They have a brushing mechanism on the inside. And here's the kicker. Competitive caps take 30 seconds to work. There's not enough time in the OR to do that, okay? One opportunity every 24 seconds. You're behind the 8 ball if you try to use those devices. And remember, now, this is not a trauma case, okay? This is a usual elective case every 24 seconds. So these other devices are not good enough. This one does it in 10 seconds. The other thing is that the syringes, normally these syringes that we use in anesthesia for induction and during the case are you name it, you'll find them anywhere, okay? Anywhere except where they should be. They're thrown on the cart, they're laying in a pile of sputum. They're sitting there completely contaminated. And we know from work back in the 70s by blog that 1 out of every 10 times a syringe tip is going to become contaminated on a single use. We know that. But there's no mechanism in the OR that allows us to control that. There's nowhere to put them. So you just throw them wherever you can put them. This station controls that environment by a docking station. These are called the docket. So they're caps that the syringe affixes to, and it allows the anesthesiologist to organize their syringes. It's likely to have a significant impact, my hypothesis, on syringe swapping because it's in an area that you can see. The resident can arrange it. That is huge for a system like that, because think about what is that relationship that I showed in the beginning, how there's a relationship between the environment and injecting the IV tubing, which is associated with increased mortality and infections. This controls that environmental component by keeping syringes out of that contaminated area. This is a big deal. So we needed to know, is this system useful? So we tested it. This was done at Dartmouth. And again, this is just a slide that I just wanted to highlight again, this relationship between the environment and the stopcock. But we tested this catheter care station, a randomized trial of 572 patients, randomized controlled clinical trial. These patients were randomized to receive the catheter care station or usual care. And we simply put the system in the OR. There was no education. We just dumped it in there because we wanted this to be pragmatic. So I said control, but it was really pragmatic. We wanted to see if providers would use it without significant direction, because that would mean it would be useful for other institutions. Our primary outcome was contamination of the stopcock at the end of the case. And the catheter care station significantly reduced stopcock contamination with an absolute risk reduction of 9%, and you only need to give it to 11 providers to prevent one event. Now, it also reduced infection, okay, with a number needed to treat of 16. Now, so that's an important point because it solidifies the relationship between stopcock contamination in the OR and morbidity. We know it's a problem. We have statistics saying it's associated with bad outcomes. You intervene in the process, infections go down. It closes the loop. And this is what the providers need to hear and they need to see when you're trying to get them to use a new device. So for our bundle, this is our component. The evidence-based catheter care component includes this catheter care system, the hub scrub and the docket. Now, what about hand hygiene and reducing contamination in the OR? How can we address that part of the multimodal program? Well, we did a video observational study to look at, it's the same study that we did, but we looked at a different outcome of what are the patterns of environmental contamination in the OR? And there are two spikes at induction and emergence. Now, that's something that you would expect, but we found that those spikes correlated with naders and hand hygiene. So we learned from this that providers are not washing their hands during these key periods, resulting in these environmental spikes. And if it gets high enough, you see it's above 100 colony-forming units per service area sampled. That's the threshold that leads to stopcock contamination. So it's above threshold here. Well, how do you get people to wash their hands when they're inducing and they're trying to keep the patient alive? Are you going to ask them to walk 10 feet away and use a wall-mounted device? Because that's what we currently have, are wall-mounted dispensers. Are you going to ask them to use a foam dispenser on the anesthesia machine? You can, but they're not going to do it. And they're going to wear gloves, and they're not even going to consider that fact, or they're just going to be focused on taking care of the patient. Most of them are not going to turn their back. So we hypothesized that what if we recognize the relationship that the more stressed you are, the more work you have, the less compliant you are, and look for a device that addresses the issue of proximity. Let's get the alcohol dispenser where they need it so they can wash their hands during induction and emergence. So we conducted a randomized trial at Dartmouth again, and 114 operating rooms were looked at, 61 in the control, 53 in the treatment, and we simply randomized them to this. Now, it isn't the device, it's just the fact that it was close to them. They weren't wearing white coats. This is Dr. Koff, primary author. But they wore it on their scrubs, and it contains 70% alcohol isopropyl with an emollient. And we just gave it to them. And they said, what do you want us to do with this? Wash your hands. When? Whenever you want to. And it had a time stamp on the inside of it so that we knew every time they used it and when they used it. And then we looked at, well, if you just give them a device, do they wash their hands more per hour? Well, here's the control group. If you look at attendings, they wash their hands what does that say? I can't even read that. 0.15 times per hour. And other providers, CRNAs and others, around 0.3 times per hour. So they're not washing their hands essentially, but if you give them the device, you have around a 20-fold increase in the amount of times they wash their hands per hour because it's close to them and they'll do it. The question is, does it matter? And now, if it does work and we're correct about this relationship between hands and the environment and stopcocks, then if you get people to wash their hands more, those things should be addressed. So that's what we tested. And we found that there was a significant drop in environmental contamination by about 100 CFU. So it got it below the threshold. And then what happened to the stopcocks? 33% here, 7.6% there, which was statistically significant. And then here's what the environment looked at baseline after we decontaminated it. Here's if you didn't give them the device, and here's if you did. So there's a significant decrease in the contamination. Did that impact infections? Yes. 21% in the control group, 3.8% in the device group, number needed 3 to 5. Infection control in the OR matters. If we can get providers the right tools, we can have an impact. There's no question about it. Any anesthesiologist or surgeon that questions that, seriously, give them the papers, and I'd like to meet them. It's definitive. So then the question was, okay, we can get to the environment by washing our hands because of this relationship, but can we target the environment more effectively? Because right now we're using rags soaked in quaternary ammonium compounds, butcher's solution, and we're having techs come in and frantically wipe it down to save time. So Cantwell Clark at Dartmouth again said, I'm going to look at the impact of improved quality. We know that we can improve frequency, right? If we can get it during induction and emergence, we could do that. What about doing a better job during routine in between case cleaning? So he looked at standard quaternary ammonium, but adding the microfiber cloth, and then layering on top of that a surface disinfection wipe that included ethanol. So 2 hits, quaternary ammonium and ethanol. And he also created a clean and dirty area in the OR for the anesthesia providers using simple plastic bins. And he looked to see, did that impact the bioburden in the OR? And the answer is yes, it dramatically reduced the bioburden in the environment. And there's a reason for that. If you look at the organisms that are involved, they don't have a slide to show it, but there are organisms that have evolved to become great efflux pumpers of quaternary ammonium compounds. And the more you expose them to that, the more effective they become at evading it. But if you use ethanol as a second hit, it eradicates them. So it worked. So you can definitely target the environment. And then in terms of patient decolonization, I know that I've mentioned that we need to do it. The reason why we need to do it, if you look at randomized controlled trials by Bodie and others, and then you look at the meta-analysis that was published by the Agency for Health and Research Quality, if you treat 1,000 patients, you can prevent 36 infections. This is what the data tells us. So if we know that we're transmitting from patient to patient in the OR and that this can infect patients, and there's a strong link between that transmission and infection development using genome analysis, why then would we not extend a cost-effective measure to everybody? Why would we not? It doesn't make any sense. So I created with my team a patient-centered, simplistic, and cost-effective program. Now, it was difficult, to be honest with you, because I was not getting buy-in from the clinical nursing staff on swabbing patients, because I'm using a screen and treat approach that's cost-effective. And they felt that it would be difficult to incorporate that into the clinic workflow and into pre-anesthesia testing. So what I did is I built a system where all the surgeon has to do is include it in their preoperative order set, and it happens. It's taken care of. So it's with the surgeon, they're operating, click the button, and this system happens. And it brings decolonization to the surgical service lines that need it. At Iowa, when you look at gynecology, oncology patients that don't do it, their Staph aureus exposure rate is dramatic, 60 to 70%. Orthopedics, hardly detectable. There's no reason why, when we're putting patients in the same OR, that this isn't a universal approach. This needs to change. And then we're working on new diagnostic development for these more pathogenic strains, and those will be coming down the road here shortly. And I just wanted to show you some of the new surveillance at Iowa and what we're doing. So to review the bundle, we're going to use the Ultraport Zero. We're using the Catheter, Disinfect, Catheter Care System, the Hub Scrub, and the Docket. That's the vascular care bundle. We're going to leverage the concept of proximity to augment hand hygiene. We're going to use targeted environmental cleaning with improved quality with the double hit. We're going to create a clean and dirty area in the environment. And we're going to try to improve cleaning during those key periods of induction and emergence. We're going to extend patient decolonization to everybody. We're going to use povidone iodine because the evidence shows that it's probably equivalent to the more expensive nasomepiricin. And we're in the post-antibiotic era, and we shouldn't be using more antibiotics, so use something beyond antibiotics. So that's our bundle. Now we're going to, when we implement it, we're going to measure it so that we make sure that we're optimizing it for the patients. Here's our target. This is the surveillance telling us at Iowa. The red indicates a dirty area. This is greater than 20 colony-forming units per surface area sample. These are all the reservoirs the system measures. I'm going to highlight a couple of them for you. This is the target. You want to get this, convert all of this to blue, and I'll tell you why. Because when you measure never events with the system, I consider, okay, if I'm getting an operation, I would consider that you injecting bacteria into my IV should be a never event. I don't want that to happen. I don't want to see that happen for my family, so that's one. The other one is if you're going to operate on my knee, I don't want the surgical equipment to be contaminated before you do it. So that's another never event here, which is the tray. So in this system, when they bring the equipment up and they open it up, we cultured it. But it was exposed to the air for a few minutes. This is before the incision was made. So here's the tray at baseline. There's a 3% contamination rate. But if you look at case 2, contamination of the tray before incision, it's supposed to be sterile, goes up to 10%. And we're talking about contamination with Staph aureus. So why would that happen? This is not they're not sterilizing it correctly because it would have been contaminated at the beginning of case 1. This is, something's happening between case 1 and case 2. And this is what's happening. Providers are coming in, we're not doing anything to control the spread of bacteria. It's becoming aerosolized, it's getting dumped into the environment, and it's ending up on the surgical tray. And then it contaminates the environment, and guess what? It gets injected into the lumen. So we're still injecting these open lumens with bacteria at Iowa. Then the system says, okay, so we have never events that are occurring at an unacceptable rate. What are we injecting? So it breaks it down, and then it tells you how to get at it. So what are the key pathogens in the never events today at Iowa? Coag-negative staph, gram-negatives, Staph aureus, and then some other commensal flora, strep and micrococcus. But this is a big one, held up again, and then it maps it out for you. 53% of the time you can find transmission of Staph aureus. It tells you where it's originating, how it maps it out for you, provides a typical transmission pattern, so then you can give feedback at the group and individual level because it leverages genomic analysis. And it gives you an idea of where your hand hygiene initiatives are working, where they're not, where the ORs are working, and where they're not in terms of environmental cleaning, because it shows you the ORs that are tagged here. And when you find these ORs that are hit, what I'm doing is I'm using this as a way to guide use of the robotic cleaning units in the OR. So I'm creating a map for them so that we know which operating rooms to use the limited resources on at night. And then we're extending this to the ward as well. When the wards are hit with more pathogenic organisms, we'll hit those rooms first. But what about gram-negatives? Gram-negatives have a different story. It's primarily at Iowa, it's obviously providers are bringing them in on their hands, okay, first thing in the morning. So what I'm going to do is I'm going to implement a surgical scrub. Before they come in, every provider, not just the surgeon, has to scrub before they go into the OR and deposit it, because if they're left to do whatever they want, it ends up in the environment here, and then guess what? They inject it. And we can't be injecting gram-negative pathogens into these patients, especially Klebsiella and others. So what I would recommend moving forward, and this is the money slide, immediately stop using the open lumen. There's tremendous evidence that this is harmful to patients, and I consider it to be malpractice that we're allowing that to occur. Implement a closed disinfectable stopcock, and then make sure they're able to disinfect their catheters. Find a tool that works for them so that they can do it. Provide them with the evidence, give them a tool that's going to work within the time frame that it needs to work for the anesthesiologist. Leverage the concept of proximity to improve hand hygiene, which is going to help you reduce environmental contamination, but also improve the quality and the frequency of cleaning as I described using those techniques. Extend your patient decolonization efforts beyond orthopedic surgery and cardiothoracic surgery, and use surveillance to measure the fidelity of what you're doing so that your providers will buy into what you're doing. They need to see it. If you want to have an impact in the OR, they need to see it, and you need to be able to monitor it and impact change and evoke change. So this is your window into that for the OR. And if you do this, you're going to dramatically improve perioperative patient safety and reduce mortality. So now I'm happy to answer any questions that you have. Thank you. Yes.
So when you say you want to decolonize university, are you decolonizing MLST testing positive, or are you not bothering with testing and just sticking it up their nose and watching them live?
I think the screen and treat and the decolonize everybody, if you look at different papers, they're both considered cost effective. You can spend up to $380 per patient to get that effect. I would recommend in the era where we're in terms of antibiotics, if you screen them, it's helpful because you'll find if they have MRSA or not, and then you can further guide prophylactic antibiotic therapy. So you get more out of it than just decolonizing. So I would say use a cost-effective screen and treat program to extend it. You're welcome.
This is a great study, great findings, but could you also so there is a repetitive and there is a training.
Yeah, those are two really good points. So how do you address, I'm going to start with the second question first. My answer to you is we need to start somewhere. And my answer to this relates to the first. So the way that you deal with your naysayer is you provide them with evidence, show them the evidence, have the ability to describe it and back it up, provide them with references, and then you go above them and beyond them to your perioperative directors and you talk about this is the benefit, this is the value, this is the cost, this is what we get out of it. And then you can ultimately affect change because it becomes a systems change. So what I did is I went to the purchasing group right out of the gates. I presented the case and they said we should be doing these things in the whole hospital. And I said let's just start in the OR. And then once you have buy-in outside the department, you bring it in. And I focus on the perioperative director initially because they get it and the surgeons, the way to get to the anesthesiologist is to talk to the surgeons. And so I've actually gone from surgeon to surgeon and I said, this is the transmission that's happening in your OR, let me show you. I show them the surveillance and they say, do you have the system up and running right now? And I said, yes. And they said, I will walk with you to any meeting I have to go to get the institution to implement this because I do not want this occurring in my OR. And I didn't even know IVs were a problem. So the surgeon is the captain of the ship, address them, and then you bring on the end users. That's what I would do. In terms of the Foley, I think that is a problem. I think that when you start doing these things, you're creating a culture of change, and the circulating nurses are a big part of that, and they're typically very responsive to these things. And I think working as a culture where the surgeons, the anesthesiologists, the scrub tech, and anyone in the OR is involved is the solution, and I believe you do that through surveillance and you show them the data and you give them feedback. Does that answer your question? Okay.
Yeah, I was just wondering, does your data, your surveillance actually lead the surgical site infection with staph aureus?
50% of the time. 50.
50%.
Yes.
So
You
that's
could,
the surveillance because, yeah, I'm having this issue and I'm seeing this and I did observe the anesthesia care and that was a concern for me and yet the surgeon said, oh, well, that's not really linked. And so I think there's a real lot of misinformation that they have.
and they don't understand how bacteria from one patient is transmitted to another. So the orthopedic surgeons think they're protecting their patients, but they're only partially protecting them because they're not controlling everything else that's happening around them. So there is definitive evidence. There's no doubt that it's linked to infections. That used to be a question, but it's definitive now.
My question is about the risk of fire in the operating room and putting an alcohol-based product 70% on the person of the anesthesia provider and the oxygen-rich environment. There seems to be a lot of concern about that.
Is that concern that that's been raised when you tried to introduce it?
I've had departments of health say that you can't even have it on the anesthesia card.
I haven't, when we were at Dartmouth doing this, that came up. And then we did another multi-center study using the same alcohol-based dispensers. And it just, we were able to get through it without any issues because the one thing that you couldn't do is store large volumes of it. But these only have a limited 3 ml per cartridge. And it was that limited volume. And then the cartridge replacements were available for the providers to get them during the case, but they weren't stored in the OR, and that was the differentiating factor. Mm-hmm. Are there any other questions? I guess not. Well, thank you very much again for attending.
Thank you, Dr. Loftus, for entertaining us this evening and really providing some really great detail. And I think what I take away from this is you all, as infection preventionists, really have a tough job ahead of you. And just the whole medical practice really it really just accentuates the need for the care that you all provide. So, you guys are all champions in the hospitals, and all us patients, we look for you to make sure that, we're safe. So, great job, and we appreciate it.
Yes, thank you.
Just 2 points. Please be sure that you turn in your CE credit sheet to the people at the door on your way out. And then I know that Dr. Loftus mentioned that the sequence of the slides were a little different. We will try to get all those out to you as a separate email to you as a PDF file in the near future. Okay? Thank you again.